Hello, everyone. Thank you for joining us for the sixth and final webinar in our series on brain injury and behavioral health. This series aims to inform behavioral health professionals in the community about the unique needs and treatment methods for individuals living with acquired brain injury. This webinar is being recorded and will be available on our website at craighospital.org/BIBH, where you can also find recordings from our previous webinars and complete bios on each of our speakers. You'll receive an email after the webinar with information on obtaining continuing education certification, as well as a link to the recording. There will also be a link to a copy of Dr. Stang's PowerPoint. And now I'll turn it over to our speaker, Dr. Bibi Stang, clinical neuropsychologist at Craig Hospital.
Hi, everybody. I'm Bibi, and I'm going to be spending some time talking about just in general, the neuropsychological assessment and just kind of how those evaluations can be used in treatment planning after an acquired brain injury. If you could please type in your questions into the Q&A, and at the end, I will get through as many as I possibly can. But if I happen not to get to your question or a question comes up later on, please feel free to use that email address and contact me. I'm happy to answer those questions. I will also be making my slides available after the presentation. Just a little bit of information about how to get those continuing ed credits, and please do so by June 2nd. Again, kind of the goals for today is to summarize some of the major areas of cognition that are assessed following an acquired brain injury. I'll also be describing the value of neuropsychological assessment in tracking cognitive changes following an acquired brain injury, and then describe the implementation of the neurological assessment results into treatment planning. And I'll be integrating a case example to hopefully make this come alive. No, nothing to disclose in terms of financial relationships. All right, so what is neuropsychology? Essentially, it's the study of brain behavior relationships, and we use a subset of standardized tools and assessments and integrate those findings and other data to kind of understand someone's cognitive changes that may have occurred. Sometimes use that data to understand, is this something neurologic versus, let's say, something psychiatric, and really kind of within this realm of acquired brain injury, we use this data to really understand an individual's strengths from a cognitive standpoint, but also their challenges, and how do we help them function in their daily life. When these various measures were created, they created these gigantic normative databases so that we can compare someone's performance to healthy adults. More often than not, these tests are standardized and factor in age. There are some measures that also can factor in education, ethnicity, and sometimes sex can be factored in as well. Really, again, these evaluations can provide helpful and unique information about an individual's cognitive, emotional, and behavior functioning after an acquired brain injury. And that information can be used in a lot of different ways. It can provide information about the severity of the injury. Like I said, kind of describe the cognitive strengths and areas of challenge, guide treatment planning, help guide the individual and the team in how this person's going to reintegrate into the community. That looks different for everybody. And it can also be helpful in terms of monitoring how that cognitive process evolves over time. I do want to mention also that not only is this testing helpful to, the treatment team or, providers who are giving care to these individuals, the individual with the acquired brain injury as well as their support network often find this information helpful in terms of better understanding their experience, and at times can be pretty validating. I want to start off by saying I feel incredibly fortunate to be part of the Craig Hospital system, and where neuropsychology and psychology is deeply integrated into our programs. And so I just kind of wanted to outline a little bit about, when would it be helpful to include a neuropsychologist in an inpatient setting and also in an outpatient setting, which I know most of you are practicing in. In an inpatient setting, if there isn't a neuropsychologist integrated on the team, it's always helpful to kind of consult one. And again, it'll provide some helpful information about the individual's cognitive, emotional, and behavior in relation to their brain injury. And that's kind of a nice entryway into starting to provide a little bit of education if the individual is ready, but also most importantly, their support system. In an outpatient setting, usually it's helpful to include a neuropsychologist if it's helpful to have additional information about their cognitive functioning to help their overall functioning and kind of treatment planning. If you happen to notice a change in their functioning during a course of treatment, it might be helpful to get an updated neuropsych evaluation. Or if, let's say, you're working with someone and it's discovered that they have had a brain injury with a change in function, have never had a neuropsych evaluation, that can happen as well. And it could be helpful to kind of consult with a neuropsychologist and get more information that way. In general, what does the kind of evaluation look like with a neuropsychologist? I mean, really, a lot of time is spent in that clinical interview state. I think it's really important to gather as much history from family members, from other collateral sources of information to really get a sense of how did this person function and do before their injury, to really be able to appreciate how things are different. I also think it's good to kind of have a sense of how is the individual compensating for some of these challenges. And I'll get more into this, but that starts to shed a little bit of light when you start asking those kinds of questions into that individual's level of insight or awareness into the impact of their injury. I think it's important to also, again, getting a well-rounded picture of the individual, kind of asking about other areas of their life that could be impacting their cognition and level of functioning. So I've got a list there of other things that I definitely try to gather more information about that could contribute to a change in functioning and cognition other than just the brain injury. And then you kind of jump into doing the evaluation. Now, the evaluation can look different for every individual. It just really depends on what's needed, either by the individual, the family system, the the treatment team? What are kind of the questions? It can be something pretty quick and easy and a short evaluation, or if we need to do like a more comprehensive evaluation. But essentially the key is knowing and understanding what is needed and what would be the most helpful for that individual. And then of course the last part is making sure to provide feedback and reviewing those recommendations, and I'll kind of go through each of these parts. So like I mentioned earlier, I was going to use a clinical example to kind of help highlight and hopefully bring some of this to life. So I had the opportunity to work with this gentleman who was involved in a fall down the stairs, unfortunately in 2018, and did sustain a traumatic brain injury. And alcohol was involved in this particular incident. Just a little bit of background information. At the time, he was in college working on his degree. He was majoring in something within the arts and communication. There was no history of ADHD or learning disabilities. His family did disclose that there was prior psych history before this injury, most notably when he was an adolescent, some depression and anxiety, and he did engage in mental health services in the past. The interesting thing was it took him a little while to find a provider that he felt like he clicked with, but the important thing is he did find someone that he clicked with and found, per his parents, found the experience helpful during that period of his life. The other thing is this is an incredibly close-knit family system. So just a little bit about his injury in the neuroimaging. He had bilateral bleeds, mostly in both temporal lobes, left greater than right, and bilateral frontal lobes, and this time right greater than left, with minimal diffuse axonal injury. When he first came to our service at Craig Hospital on the inpatient side, he was approximately 1 month post-injury. He was in a post-traumatic amnesia, so he was not tracking day to day. His expressive language, so what he was saying, seemed confused and didn't always fit the context or the situation. We did discover that his yes/no responses were more consistent when asked to answer with a head nod or a head shake. Basically, what he was trying to say wasn't matching what he was meaning to say. He was also pretty perseverative, so kind of stuck on certain ideas. That was hard for him to shift. His mood was quite ranged quite a bit throughout the day, from irritable to sad to euphoric. And his biggest concern, which he was able to kind of let us know, was his fatigue and headaches. I did wait to complete kind of this initial neuropsych evaluation approximately 9 weeks post his injury. I really wanted to wait for him to emerge from that PTA status, and I'll get more into that in a bit. I want to talk and spend some time about, in general, what sorts of cognitive domains does a neuropsychologist tend to look at after an acquired brain injury. There are definitely a lot of different avenues that someone can go down depending on how someone is presenting, but in general, these are kind of the areas that we tend to explore and better understand. We do have some premorbid estimate standardized measures that we could use to kind of give us an idea of where someone was functioning cognitively before the injury. But we also have to factor in vocational history, educational history, those sorts of things. So again, kind of looking at the big picture. The two things that I'm most interested about after a brain injury is attention and processing speed. Now, I've listed a few things under that attention piece that kind of make up attention, but there are more components to it. but these are the ones that I tend to see the most changes in after an injury. So we've got our basic attention, so just being able to attend in any kind of environment, whether it's busy, quiet. We've got a selective attention, so that's really being able to focus in a busy environment and kind of tune things out when we don't need to pay attention to them or they're not important. So an example of that would be, let's say, can the individual attend to what their therapists are saying in a busy gym? Or, another real life experience would be, attending to a conversation while in a busy restaurant. The other one that I wanted to spend a little bit of time on is divided attention. This is definitely a more complex cognitive ability, and that's really our ability to attend and process to more than one piece of information. And this is really what is required for a lot of driving sorts of tasks. You have to pay attention to your speed, what other drivers are doing, if the radio is on. There's a lot of a divided attention that goes into just being able to drive a car. The other thing that I really look at after an acquired injury is processing speed. Our ability to kind of interpret, synthesize, come up with some sort of response takes really the whole brain working together in an efficient, synchronized manner. So oftentimes we'll see a slowed processing when it comes to one or multiple modalities, whether that's hearing, seeing, smelling, tasting, those sorts of things. And we do have measures that can factor in, with, a motor component, so using our hand to write or type or something, or without, just using our words. Another cognitive domain that I commonly look at is memory. And in order for us to really remember and recall information accurately, we need to have intact attention and thinking speed. We need to be able to attend to the information as well as process it efficiently. Again, whether it's verbal information or something that we're seeing, go through a process of encoding that information, storing it in a place that we can later find it. And oftentimes we'll see a disruption in any of those processes after an injury. And the way in which we are able to test, we can sometimes figure out exactly where that breakdown is for the individual. And it's oftentimes helpful for the team to know, all right, the breakdown here is not necessarily the attention or processing speed, but the encoding piece. And this is how we can kind of switch things around to help them learn new information the best way during this phase of their recovery. We're able to look at, like I said, verbal and visual memory, and we can look at verbal memory, whether it's structured, kind of like in a story format, does that help, versus unstructured, a random list of different words. And again, that just kind of gives us some good information to help them understand and learn and those sorts of things. Let's see, I think it's also important to note, and I'm sure some of the others have touched upon this, is, short-term memory tends to be tough after a brain injury, especially when it's localized in certain parts of the brain. But the individual will always have a gap of memory missing in their story. They never remember the actual incident that led to their injury. There's always going to be that gap. And depending on how big or wide that gap is, really depends on the severity of the injury, were there other substances involved. So I just wanted to put that caveat out there that there'll always be a kind of a gap in someone's memory, and that's part of their journey. Another area that we look at are visuospatial and visuoconstructional abilities. So that's kind of being able to see and organize things in space, putting things together, but also knowing kind of where your body is in space as well. This can look a lot of different ways. It could actually be like vision field cuts, or the brain not attending to certain sides of the body. I mean, the eyes are working and they're getting the information, but the brain is not able to make sense of the information that's coming in. It can also sometimes look like, difficulty knowing how to use a toothbrush, or difficulty knowing how to put a t-shirt on. It can look a lot of different ways, and oftentimes it's helpful to have additional information from other team members about how this particular cognitive domain is impacted. We also look in conjunction with speech therapy, language abilities, really looking at it, receptive language and expressive language. So receptive language, really understanding what is the person able to understand and comprehend of what is being said to them. And then in terms of expressive language, are they saying what they are meaning to say? Are they saying the right words, or are they having a hard time finding those right words? I think it's also interesting that when we're looking at language, sometimes what we'll see is there's a change in someone's ability to either change the prosody of their voice, and sometimes even having a hard time understanding. Let's say if we're making like a sarcastic comment, or we're saying they're not quite registering the prosody of someone's voice, which can kind of lead to some tricky interpersonal skills. But that's another thing that's is important to take a look at. Another huge area that's really important, but sometimes a little harder to capture on testing, is that executive functioning. Really, the executive functioning is housed in our largest lobes, those frontal lobes. And so as you can imagine, after an acquired brain injury, we can see a change in the executive functioning, which it's kind of like the CEO of our brain, where it kind of handles these higher level thinking skills. And I've listed a few here, but of course, there's so much more that could go under that list of what executive functioning is. And the nice thing about our standardized tests is, yes, we're in a quiet room, with minimal distractions, and we can kind of get a sense of some of these executive functioning measures. But I think it's also important to factor in, what is the individual experiencing out in the community, and what is family noticing? Our measures are definitely not perfect. They definitely shed a little bit of light, but getting that collateral information and an understanding helps understand how executive functioning has changed as a result of the acquired injury. Let's see. Another thing that we commonly assess are changes in mood, as well as personality that can happen as well. Sometimes, understandably, these are devastating injuries, and that comes with a slew of different emotional reactions. But it can also be part of the neuroanatomy and part of the injury, where there's a neurologic explanation for that shift in mood. So it's important to also kind of think about that and making sure that we're assessing and monitoring those as well. I wanted to spend a little bit of time talking about insight and awareness after brain injury. This is something that we do commonly see, not with everyone, but it is something that's important to keep in the back of your minds when you're working with, folks with brain injury. And really, it's a lack in the ability to reflect and really appreciate what's different. And it can look a lot of different ways. It can be, a motor function, not having a lot of awareness about, social situations, maybe not having awareness about certain behaviors, maybe how their memory has changed. It can look a lot of different ways, but it's definitely makes it much harder on the family system or the caregiver if they're constantly having to remind and confront that with the individual. It also has some hindrance to someone's ability to fully engage in neurorehabilitation. In my experience and in the literature, that insight and awareness tends to evolve over time. And sometimes what can happen is someone's insight starts to increase, or their awareness is building about what's different. What can come into play that kind of can be a hindrance is some of those emotional coping styles. Where, let's say, they weren't the type of person before this that liked to get feedback and would incorporate that feedback. And so oftentimes they would engage in denial as a coping strategy. So it's this kind of evolving thing over time, where you can actually start getting a mixture of, yes, it's a little bit of the brain injury, but also now we're starting to get into premorbid coping styles. And it's it can be a challenge, but it's something that you can definitely, with rapport, that strong working alliance, work on with an individual and their family members as well. So kind of jumping back to my clinical example with Mr. X, just as a reminder, I waited about 9 weeks before I did some initial testing with him. Again, I wanted to wait until he got out of that post-traumatic amnesia state. This is just kind of in general my findings. My premorbid estimates kind of put him into that average range. He did show impaired attention, slowed processing speed. In terms of his memory, his verbal memory was impaired. However, his visual memory was slightly better, but still not quite to where it was compared to his premorbid estimates. But this was helpful information for the team in terms of, let's try and make most of our new information for him in a visual format. I was able to look at a little bit of executive functioning, and what was tough for him was kind of some of that divided attention sort of tasks. He had trouble with incorporating feedback, trouble with self-monitoring, and difficulty with rule following. And I think what was tough with this particular individual was he did have poor insight. So as a team, we had to work hard to get him engaged and help him understand why we're working on the things that we're working, because it was hard for him to appreciate what was different. In terms of his visuospatial and constructional abilities, that was within normal limits. That looked good. And again, it was kind of a balance of balancing his strengths with trying to tackle the areas that are harder for him. And these findings were congruent with, where his brain was injured, the medications that he was taking, as well as observations on the floor by myself and other team members' reports. So once the evaluation is over, it's important to really take time in providing feedback. And there's a lot of value in making that process in a safe space that it can allow for various emotions, even anger. So in a sense, trying to create a space where it can be therapeutic and kind of going over the findings of the evaluation. Sometimes this is the first time that family members, even the individual with the acquired brain injury, is learning about their injury and how it's impacted. So it at times can be pretty validating to hear, like, okay, this is a challenge and that is my experience. What I normally like to do, again, is kind of making sure that I'm addressing the questions of the individual as well as their support network. Discussing what sorts of, depending on where their challenges are, what sort of compensatory strategies they can be using. Taking the time to really discuss about what are those next steps, what are my recommendations. And then also, of course, I think this is really important, which I'll touch upon again later on, is making sure that these findings are communicated with the treatment team, referring clinician, whomever it would be beneficial to know that this information. I think it's also important to kind of keep in the back of your mind when we're sharing this kind of information that not every individual is ready to hear everything. Whether that's related to poor insight, poor awareness, or just how they're coping with the situation, they may not be ready to hear everything. And so the approach that I like to take is kind of planting seeds. Kind of putting these things gently out there in a way that's digestible, and hoping that there's an opportunity maybe later down the road where they can reflect or something can become of that seed. This is a tool that I commonly use because it's concrete, and it kind of just visually shows where their cognitive domains fall on just kind of the bell curve. This tool is it can be really helpful to kind of start building some of that insight and awareness into how things are different, because this is such a concrete tool. And of course, I adjust it and move it however it is that the person's results are looking, and adjust their estimated premorbid level of functioning as well. But it can be just a helpful concrete tool to help someone really visualize and start seeing, all right, things are different. In terms of recommendations from these types of reports and these types of, evaluations, it's going to be different for every individual, depending on their inpatient, outpatient, and kind of what their goals are. But I kind of highlighted here kind of what are the key things that I'm thinking about in terms of when I'm making those recommendations. On the outpatient side, there's oftentimes questions about, level of supervision. Maybe their maladaptive behaviors have changed since being out in the community, like what sorts of suggestions or strategies would be helpful. More often than not, folks really benefit from additional emotional support. Like I've mentioned before, their world has been turned upside down, whether it's, individual therapy, but also oftentimes the family benefits from some emotional support themselves. And usually making a comment about, what are the next steps? Would it be helpful to do another evaluation to kind of monitor, or are we not quite ready for some of those higher level things like going back to work or school, those sorts of things. Again, it depends on what the person is needing. So how do we go about incorporating these findings into treatment planning? I know I already highlighted this, but really communication is key, and this is a collaborative process. Acquired brain injury takes a village. And so really looking, again, the person as a whole person, really communicating with each other about, hey, these are the individual's strengths. These are the areas that are harder. These are the methods that are going to work the best in terms of, whatever it is that they're working on, whether it's work, school, driving, increasing their level of independence in the home. The evaluation can definitely shed light on a lot of those different areas. I think it's also really important to kind of partner with the individual as well as their support network and building buy-in. Oftentimes, people really want, they see the long-term goal, returning to work, school, driving, and those might be a way off for some of our folks. And so really it's making sure they feel heard and that that's their long-term goal, but also helping them see and appreciate that these are more achievable short-term goals to get you to those long-term goals. And sometimes it's also kind of planting those seeds depending on whether or not they're ready to hear, but that those long-term goals may not be completely feasible, or they might look different than what they're kind of envisioning. And then of course, during the evaluation, if we're learning, that depression or anxiety is really getting in the way of their thinking skills, making sure that we are helping them find those resources to address those, or if something's going on that's a particular stressor in their life, or they're looking, to kind of redefine themselves and discover who their new identity is and rediscover that sense of purpose and meaning. There's different ways that we can go about in supporting them and addressing those other contributing factors. And just to kind of hammer it home, it's always helpful to kind of start with what's the most motivating for the individual and kind of build from there. All right, so going back to Mr. X. So on the inpatient side, I had I've got a little bit more information to tell, and then I actually followed him as an outpatient. So while he was an inpatient, like I mentioned, we really focused on just trying to build buy-in, given his poor insight and awareness. So a lot of that was just spending lots of time building rapport and building that trust. And in a way, kind of getting him to do therapies, but not really realizing like, oh, this is therapy. We're doing something else that seems kind of fun with this person that I'm getting to know. And then of course, continuously changing our strategies based on how he was progressing and improving over time. Making sure that we were teaching him new materials and ideas and the way that he could learn best. Providing emotional support and education with family was really important in Mr. X's care. And then utilizing medications to address irritability and poor attention, as well as implementing behavior management strategies to kind of help curb some of those things. When he transitioned into the outpatient program, I did do repeat neuropsych testing at about the 6-month mark post-injury. At that time, on testing, he did show some good improvements in his attention, thinking speed, and his visual memory. He did continue, though, to demonstrate difficulties with executive functioning, like solving new problems, thinking flexibly, being able to kind of perspective take, as well as continued difficulty with his verbal memory. However, despite these challenges, he did have increased insight into his cognitive and physical challenges once he transitioned into the outpatient. Oftentimes, we kind of see a big jump inside a building when someone goes from inpatient back out into the community, because things are not as easy, or things are definitely looking different. So oftentimes we'll see a nice change in that realm once they're out of the hospital setting. Because he had that insight, he was more willing to work on higher level thinking skills, and more willing to work on just kind of more foundational skills to help with his long-term goals of going back to school and driving. His poor insight did continue more into his substance use and mood. But at this point in his treatment, we were kind of teetering, like, yes, that poor insight is part of his injury, but also we're starting to hit some of his premorbid coping styles where he often engaged in denial. We were, as a team, able to get him back to driving at work and school. And towards the end of his time here in our outpatient program, he was more willing to engage in a substance use program, AA with a close friend, and he wanted to transition to a provider in the community, which was really helpful that he had worked with someone in the past and had a really strong working relationship with. And so in that sense, it was helpful, and I helped facilitate a warm handoff in terms of how to best work with him given his cognitive challenges. And then, of course, continued to provide support with family and providing education. In terms of monitoring cognition, typically follow-up testing is done at 3 and/or at 6 months post-injury. Oftentimes repeat testing at that 1 year post. And then after that 1 year postmark, sometimes testing is done again if there are significant changes or improvements, and it would be helpful to have updated testing. And really the value of that kind of updated testing is being able to track progress over time, update treatment recommendations as needed, as well as help guide community reintegration. And I know I put it down around the bottom in the asterisk, like when you're doing these repeat testing, it's really important to get good information about how they're functioning outside of these office walls. What compensations are they using? Because during the testing, they can't use those compensations, because that really helps you kind of think about the person as a whole person and not just this individual sitting in a quiet room with limited distractions. Back to Mr. X, like I mentioned, we did repeat testing at 6 months post-brain injury. It was helpful in guiding his return to driving, work, and school, in addition to the assessments that his team completed. And then, unfortunately, at about 18 months post his injury, he experienced an unexpected seizure that led to a ground level fall and, unfortunately, a brain bleed. So that was an opportunity, to do some more testing because he had a change in medical status. And we were able to complete some very limited testing because his new challenges after this brain bleed led to difficulty with reading. He did have a pretty significant visual field cut where he couldn't see his entire environment, as well as challenges with visuospatial abilities. So for example, he would have difficulty finding certain foods in the fridge, as well as difficulty finding the right words to express himself. Interestingly though, after this injury, he had really good insight into what was different, which of course was emotionally devastating because he had made so much progress. So a lot of our time together after this particular injury was spending time processing his anger and his sadness, as well as his nervousness about, will this happen again? And then eventually we were able to get him to a place where he felt confident and comfortable transitioning back to his provider in the community, and again was able to facilitate that warm handoff for him to maximize those sessions. So just in a nutshell, neuropsychology and these evaluations can really provide some helpful information about one's cognitive, emotional, and behavior functioning. It can be used in so many different ways in conjunction with all of the other information that other providers are giving and collecting. And it's just another added opportunity to holistically appreciate the strengths and challenges of an individual following an acquired brain injury. Thank you all so much for your attention, and I will go ahead and look into the Q&A box and get through as many questions as possible. Let's see. Someone's asking, can you please share the premorbid estimate tools that you use? Absolutely. So it depends on the age, because that does factor in, but the one that I like to use the most, if it's age appropriate, is the Advanced Clinical Solutions Test of Premorbid Functioning. I want to make sure I'm not missing, maybe in the chat box. Let's see. Oh, sorry, I apologize, didn't see this one here. What personality measures do you take? That's a trick. So the best way that I can answer is it depends. I mean, it's not something that I usually do with everybody, and it's usually more on the outpatient side because from a cognitive standpoint, they can, and energy wise, can withstand, let's say the MMPI, which is one that I like to use. But it's one that I kind of have to think really thoughtfully about whether or not that's going to be helpful. How often does neuropsych see an inpatient? Daily, weekly? That really depends on what the individual needs. I have had folks who needed those daily sessions, or family members that need that daily contact. And then I've got, some who just need a quick check-in once a week, but of course, over their course on inpatient, that might change. So really, I take a very flexible approach in terms of how often I see, and really kind of tailor that to based on what the patient needs and what the family needs. What meds do you use for irritability and poor attention? So those are decisions that I definitely don't make. Those are the physiatrist and the physicians that make those calls, and sometimes our consulting neuropsychiatrist. But I do help in providing like data collection if we need to monitor attention, or if we need to track how often is someone irritable throughout the day, kind of have help collect in that data process or data collection process. Let's see. Perfect. Okay. Let's see. Great. Someone's asking about how do you determine your premorbid estimates on the curve? So again, kind of taking all of these using the tools that we have that are standardized measures. I mean, then it kind of maps it out on, all right, this person may have been in a high average range, but you know what, I also have to factor in, did they have any learning disabilities? What were their grades like in school? What was their vocational history like? It's kind of we've got the standardized measure to kind of help guide us, but we also have to factor in all of the other things that make a person a person. I hope that helps. Looking through and make sure I'm not missing anything. So one question, are there some free or low cost cognitive rehab activity resources you could share or point us to? I'm gonna have to think about that one. And maybe what you could do is shoot me an email, and I can follow up after I have a chance to kind of think about that one. I want to make sure I send you to a good spot. Got time for a few more if you wanted to type them in. Oops, let me see. All right, I'm not seeing any more questions come in. We've got a few more minutes. I'm happy to. And of course, if questions pop up later on, please feel free to email me. I definitely want to be a helpful resource. I see a question here about fatigue. Absolutely huge issue for folks after an acquired brain injury. And so it's starting to help them understand that their energy reserve is a lot different than before the injury. They don't have that extra reserve to kind of push. They have to listen to their body, their what it's telling them that they need to take a break and honor it. And that's something that they could struggle with for quite a while, and maybe even in the long term. And so sometimes what's helpful is knowing what's planned in the day, what amounts of energy is going to require in each demand, and scheduling in rest breaks. Sometimes it's helpful to talk with a medical provider to see if there's something else going on, just to make sure that we're not missing something. But that is a common issue after an acquired brain injury. And what I have found to be helpful is, again, providing that education and giving them the knowledge and tools to know how to plan out their day, know what energy is going to cost in which situation, and how they can maybe bunt something over to the next day if they know that they're not going to have that energy to get to fully attend to something. Let's see. Sorry, I'm looking through. I see that there's a question about the use of CBD oil with those post-TBI, and I am still trying to keep up with the literature as it kind of comes out, and I don't have a really good answer. I'm sorry about that. I mean, more and more information is coming out about these, about the use of CBD, marijuana after brain injury, but I don't have a solid answer for you. I'm sorry about the CBD oil. Let's see. Few more minutes here if there's any other questions, but again, feel free to reach out to me by email. All right, well, we'll go ahead and wrap up there. Oops, sorry, I got my references here. Again, I will make these slides available. Yeah, make these slides available. So just as a reference.
Great. Thank you so much, Bibi, and thanks everyone for joining us. You'll get an email that will have a link to the recording, and then we'll also send you a link to Bibi's PowerPoint. Thank you.
Thank you.